Hello class, Dr. Mike Burford here, talking with you today about psychopathology. And one of the things I want to do today is just give you a basic introduction to our course and what you can expect from the course, and I want to go over the syllabus. Of course, I know when I was a student, one of the first things I wanted to know is, well, what's required of me and that kind of thing. And then I've got some information about psychopathology in general that I want to share before we move on to other parts of the course. So again, I'm Dr. Mike Burford. I have a PhD and an LCSW, and I am a practicing clinician. So let me tell you just a little about me. I always like to know who I'm working with, and that's true if I have a professor, or it's true if I have a physician or some other provider that is giving services, providing services. I like to know a little about their background. First of all, I teach in the social work program here at ETSU, of course. I teach bachelor's students and master's students, such as yourselves. I also teach in the Department of Psychiatry over at Quillen College of Medicine. And I teach psychiatry residents there, third-year residents. I teach them to do psychotherapy. And so I enjoy teaching, enjoy seeing people develop and grow, and it's pretty fun to see students do that. Like I said, I'm also in clinical practice. I've been in mental health, the mental health field for over 20 years. And I've worked in a variety of settings. Started out in my first job as a night shift psychiatric technician, walking around doing bed checks and taking blood pressures, and worked my way up, and had a variety of positions there. Eventually became an administrator, and then eventually a therapist. And of all the positions I've had, I've enjoyed being a therapist most of all. Wanted to be a therapist for a long time, and really enjoy that aspect of my job. I've served a variety of populations over the years, from children to older adults and everybody in between. I've done individual therapy, group therapy, family therapy, couples therapy, substance abuse work, you name it, and chances are I've done at least a little of it. So I also do some research and have done some research. My research interest focuses around existential psychotherapy. I've also done some research in the past on schizophrenia treatment. Currently have a project going about attitudes about poverty, and have done research on adolescent runaway behavior and interpersonal relationships, and have had some things published along those lines, and a few other things as well. All right, so enough about me. We need to review the syllabus, and so that's what we'll do right now. And of course, your syllabus can be found on the content section of your D2L site for this course. I want to tell you about the books. Now, there are two books that I'm going to require that you get that I think will help you develop clinical skills. One is the Bible book. Now, that's the standard textbook that we use, and it's called Abnormal Psychology. It's the third edition of that book, and it's a pretty informative book. And it's the book that we've used for the last several times that we've taught this course. The second book that I'm going to require that you get is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. So it's the DSM-5, and that's put out by the American Psychiatric Association. The Bible book is available in the bookstore. The DSM-5 may or may not be, but you can get it at just about any bookstore, including ordering it online if you like. The thing about the DSM is that if you intend to become a clinician and practice as a clinician, you will need most likely the DSM-5. especially if you're doing diagnostic work and that kind of thing. I use the DSM-5 fairly regularly, and the other clinicians, the psychiatrists and social workers and psychologists that I work with, we all use the DSM-5. It's a pretty big book. None of us know the book inside and out, and so it's an excellent reference. And my goal for you as my students is that when we get through with this course, my goal is not that you know the book inside and out, the DSM inside and out. My goal for you is that you understand how to use the DSM as a reference and a guide, and that you're able to use it to find the information you need. And then later on in your career, you'll probably use it enough and use certain parts of it enough to where you may know it by heart, at least sections of it. But certainly that's not our intent for this course. I just want you to be familiar with it and be able to use it. In fact, it'll be useful for the diagnostic exercises that I'll have you do. Now, there's a book that's highly recommended. It's by D.H. Barlow. Well, he's the editor of it anyway, and it's the Clinical Handbook of Psychiatric Disorders, a step-by-step treatment manual, and that's in the 4th edition. I find that to be a pretty informative book. Now, the other thing is that I will probably post articles on D2L that I want you to read too, or at least give you the information and have you go look that article up, which is actually probably a better idea. I want you to have the skills to be able to use the databases in the library and to be able to look up articles and find them, read them, and be able to interpret them. I think that's an important skill for every clinician to have. In my private practice, I remember there were times when other clinicians would come to me wanting to know my opinion about something clinical related, and I think that the reason they did that was because I made sure to get in the literature, the research literature, and to be aware of current treatment modalities and that kind of thing. Sometimes I've had another clinician tell me something, and I'd say, well, how do you know that to be true? And they say, well, so-and-so down the hall told me, or I heard that somewhere, and that kind of thing. And it turns out it may or may not be true at all. It may sound good. It may have what we call face validity, but in fact, it may have no validity to it at all, and may not be accurate. And so a good clinician is a clinician that's able to get into the literature and keep abreast of the new and the latest research that's out there. In this course, I hope to get you to do that, to be able to learn to use the databases if you're not already able to do that as master's students. But I can't imagine a master's student that graduates that doesn't know how to use the social science databases and look up articles. So that's going to be really important for you in your career, at least I hope. It will be if you're a good clinician, if you become a good clinician. All right, moving along in the syllabus, you'll see that there's an outline there, and in that outline, I'll have 10 different units, and there will be 10 units reflected in D2L as well. But in the outline, it will tell you what we're studying, that particular unit, and you'll be able to see the readings for following classes. And in that outline, I also have when things are due. For instance, when your exams are given, when they're due, and your papers and so forth. And it's pretty straightforward. I've spent quite a bit of time making this as user-friendly as possible. And then if we scroll on down in the syllabus, you'll have information about your assignments. All of that's pretty clear. I would imagine that it clears up any question you may have. However, if you do have a question, be sure and send me an email, and I'll be happy to clear that up for you. If I have 2 or 3 of you that ask the same question, what I'll likely do is go to D2L into the news section, which is the front page of your D2L site for psychopathology. and I'll make a statement for the whole class that provides any needed clarity. So what you're going to have is you're going to have 2 exams, one about halfway through the course, and the other exam will be about almost at the end, and they will cover the material that we have covered up to that date. Now, the second exam will only cover from the material covered from the last exam. Okay, it won't be a comprehensive exam, the second exam. You'll have a literature project to do. You'll notice when you read the instructions that I don't have a page requirement. You're master's students, and I will leave it up to you in terms of your page requirement. Now, here comes the kicker. It'll be up to you to make sure that you meet the requirements of the assignment. And if it takes you 5 pages to do it, so be it. If it takes you 30 pages to do it, that's probably a bit excessive. However, when I was a master's student, I had to write 30-page papers, and it wasn't anything that killed me, obviously. So if you happen to have a 30-page paper, then that's okay too, as long as it's not a paper that's tangential and full of fluff. You know, nobody needs that. But you don't need to read it, and I don't need, or you don't need to write it, and I don't need to read it. But you have liberty to take up as much space as you need to write your paper. Now, one of the things that I'm going to insist upon with your papers, with all of your written work actually, with the exception perhaps of your diagnostic exercises, is that you use headings and if needed, subheadings. Headings will help organize your paper. It'll help you write the paper. It'll help me read the paper. So dividing your paper up with headings is a very appropriate thing to do. What I found in the past with students that don't use headings is that they'll tend to ramble and things will be unorganized, and then it's a matter of having to say, well, you know, did this person meet the criteria and the things that need to be in this paper or not? And so then it's like going on an Easter egg hunt. Maybe I'll find the egg, maybe I won't, but in the meantime, it's turned into a mess. So anyways, please use headings for your papers. You also have a personal project, and that could be a paper of some kind, a term paper, if you will. It could be a book review, it could be a film review, it could be an interview that you've done. You've got quite a bit of latitude on that. So information about that, again, is in your syllabus. Class participation, that's very important. Obviously, this is an online course, and so what I intend to do is have discussion boards for you to participate in. What I found in the past is that students tend to really get into the discussion boards and enjoy using those, and it's a forum for you to express your ideas, respond to the ideas of others, have them to respond to your ideas, and all of that. Oftentimes, I'll get on the discussion board and participate, and my opinion may be different than yours. And unless I flat out tell you that you're incorrect, then that's fine. And it's okay to be incorrect too. I mean, that's while you're here, you're a student, and your job is to learn. I don't expect you to know everything. But in some cases on discussion boards, my opinion will differ from yours, and it's not that anyone would be more correct, and you would certainly have your right to your opinion. But sometimes I get on there and mix it up with people, and I invite you to do that and not be afraid to do that with me. I'm not going to give you a big fat F because you disagree with me. That's not the way this works. In fact, what I prefer is that you use critical thinking skills. I don't mind you at all to express your ideas and opinions. What I want you to do, though, is to be able to back those up. Whether you do it with literature from the research literature from the databases, or some kind of personal experience, or what have you, I want you to be able to tell us why you believe what you believe. Finally, you'll have 5 diagnostic exercises. These will be cases that are fairly commonly seen, things to help you get used to using the DSM, looking at a case and trying to provide a diagnosis for that. I won't penalize you if you come up with an incorrect diagnosis for each case. However, I want you to do your best and try to nail it if you could. What I do want to see is evidence that you've used the DSM, and I want you to be able to tell me why it is that you think a person fits whatever diagnosis that you've provided. So that'll be some useful exercises. Some of the cases will probably be relatively easy, and others maybe not so easy. But I've certainly not done anything in there to try to stump you or any of that. If I recall, I don't think I've given you any cases that have several different diagnoses, that kind of thing. So I think all of them just require one diagnosis. All right, so for your 2 exams, they're worth 20% of your grade. Your personal project and your literature review, each is worth 20%. And then class participation is worth 10%, and diagnostic exercises is also worth 10%. And then the rest of your syllabus talks about mostly about guidelines for scholarly work, information about disabilities, and other things that the university would want you to know. I do have some information about how I will grade your papers. So anyways, what I require you to do is to look at and read your syllabus. And please do that before you decide to send me an email asking me questions. I don't mind at all to answer your questions. Now, it may take me a day or two to get back to an email, although I try to do those in a prompt manner. But one of the things that really annoys me is when somebody sends me an email or asks me a question that is already answered in the syllabus or already answered on D2L. So be sure and read your syllabus before you ask questions. Now, let's talk just real briefly about D2L. Hopefully you guys are familiar with D2L. If not, ETSU has a center in the library that can help you get up to speed on D2L. Be sure and check the news section regularly, because I will post things on there that I want you to know. Sometimes I'll do that as opposed to sending out a mass email to the class. In the content section of D2L, you'll find the different units, the 10 units, that will have requirements for you to do. And I'll put the syllabus in there. Videos will also be found there. I'll probably have some videos for you to watch and that kind of thing. So a lot of the work that you're required to do, directives for that can be found in the content section. There is a section, if I remember correctly, it's called assessments. That's where you'll find your exams. That's where you'll find the drop boxes for your papers and written assignments. Discussion boards can be found under communications. So there'll be a communication section in D2L. You click on that and you can go down to the discussion boards. About the APA manual. Now, you are required to do your writing in APA style, and I'm a stickler for that. I can tell you that when I was in private practice, sometimes I would have something come across my desk, a letter, or something to that effect, some kind of communication to me, sometimes from another provider, sometimes from somebody from court, or somebody from the school system if I was working with a kid, sometimes from families, that kind of thing. One of the things that I can tell you as a professional is that if I get a letter or some kind of communication from another professional that's poorly done, that's poorly written, then almost immediately I question whether that person is competent as a professional. And I wonder why they can't write better than they do. And I wonder why that they aren't using basically the APA style that's pretty much drilled into the heads of students in graduate programs. And it's done so for a reason. It provides a really nice format and a logical way to write. It's a really nice, clean way to write in terms of organization and that kind of thing. So, if you, as a professional, want people to think well of you, then you need to be able to write appropriately. And part of that is being able to use APA style. So it's mandatory for my class. And again, I want you to use headings to organize and divide your papers. You need to get an APA manual. If you don't have one, you'll need one. So you might as well do yourself a favor and go ahead and buy yourself an APA manual, because I can promise you that you will need it time and again in this master's program. Otherwise, you'll have to be using either secondary information for APA style or making unknown trips to the library to use theirs. So go ahead and buy yourself one. You'll be glad you did. And that way, too, you can make little marks on it and little page notes and all that, and little ways to indicate what page something's on, some of the little sticky things that stick out that'll let you know, oh, okay, well, the references are right here. I don't have to go back to the index to look up this particular thing that I want to know because I've already got it marked, you know, things that you commonly use, for instance. And again, I've already said something about the DSM-5. I'll say more about that shortly. I want to cover some useful abbreviations in writing. If you see DX, that means diagnosis. If you see TX, that means treatment. And if you see HX, that means history. Now, something else I want you to know is that I will not cover every psychiatric disorder that's in the DSM or in your textbook in my videotape lectures. But I will cover the disorders that I see regularly and have seen often in my own psychotherapy practice with clients. I will most definitely cover things like major affective disorder and generalized anxiety disorder and schizophrenia and bipolar disorder and some of the more common disorders that I see, personality disorders and that kind of thing, substance abuse, all of that. I would rather spend more time on those particular disorders because I know that if you become a clinician and go into practice, whether at an agency or private practice someday, that you will be seeing these kinds of disorders and that you'll see them frequently. So I'd much rather spend time on those as opposed to some rare disorder that you may or may not ever see in your entire career. Okay, well, let's start with a good definition. What is psychopathology? Basically, it's mental disorders, the study of mental disorders. Ology means to study something, right? So basically, it's mental disorder, mental illness. Disorder is a mental problem that becomes a disorder if it disrupts one's ability to function in their daily life, such as in social, occupational, or educational areas. So if a mental problem impedes a person's ability to function in various spheres, one or more spheres of their life, then it becomes a disorder. Now, that's interesting because it may be that somebody has, for instance, characteristics or traits of, for instance, obsessive compulsive disorder. It may be that a person, before they go to bed, checks the doors a couple of times to make sure they're locked. Or perhaps they check the stove a couple of times to make sure the stove's off. Or perhaps maybe they've been out working in the garden and they come in and they wash their hands, and a few minutes later they feel the compulsion to wash their hands again. That's not obsessive compulsive disorder. Now we may say that there are some obsessive or compulsive traits there, but it's not a disorder unless it disrupts that person's ability to function. Then it becomes a disorder. And so what I've seen over the years and noticed with people is that people can sometimes have various characteristics of a disorder without actually having the disorder. So you might want to keep that in mind, the true definition of a disorder. Now, what I want to talk about here just briefly is the differences between the medical model and what I'll call the social work model, which actually includes two different models. So, but first let me tell you a little about the medical model. Now, you're probably all familiar with the medical model, whether you realize that you are or not. The medical model is the traditional, widely accepted model that's used. It's the model, of course, when you go to your physician and you've got a snotty nose or some kind of itch, or maybe you've got pleurisy, or maybe what my grandmother called the bots, which is stomach distress. Maybe you have some malady like that, and you go to the doctor, and what does the doctor do? Well, the doctor or the nurse practitioner or the physician assistant or ever who's seeing you presents themselves as the expert. They see you as the patient to be worked on. They come in, they identify a problem, they treat the problem, and of course, diagnosis is made. And by the way, I want to tell you, I can't remind you if you don't already know, but I want to tell you that diagnosis is important for insurance purposes. So for instance, in my work as a psychotherapist, if I want to get paid by insurance companies, I need to provide a diagnosis. I've heard many people say, well, I don't believe in diagnoses, and I want to take a different perspective, and I don't think it's useful to have diagnosis. Well, I hear that argument, and I think there's at least some validity to it. But on the other hand, I can see some pretty strong reasons, if diagnosis is done well, that it's useful. And I'll talk more about that shortly. But anyways, the medical model, again, it's widely accepted. It does have the medical lobby behind it. That's a pretty strong lobby. They also tend to have plenty of resources, and traditionally, and even currently, they are the dominant model, the medical model. And when I say they, I'm talking about the medical folks. Okay, and then we have the social work model. It's a newer approach. It's less widely known and accepted. Has less resources, I would imagine, than the medical model. Although we do, at least in the state of Tennessee, have a pretty decent lobby. And I've met our lobbyist that we have down in Nashville. He's a very nice fellow. If you get a chance to talk with him or meet him, by all means do so. In the social work model, of course, we take the ecosystems approach. we want to look at the person and environment. We don't focus just on the person. We focus on the systems that that person operates in and all the things that could be influencing that person or impacting that person. And I'll give you a really quick example, a case example. I remember one time I was working with a parent, with a woman, and her son. And her son had behavioral problems. Her son was violently aggressive and would frequently have huge tantrums. He would frequently hit his mother, would fight other people, would fight authority figures. And when I say fight, I mean he would fight. He would hit, physically fight, kick, scratch, punch, bite, spit, you name it, he did it. Pick something up, hit you upside the head. He was a pretty violent little fellow. I think he was right around 10 years of age or so back when I knew him. This was many, many years ago. And I remember one time I was sitting with them. I worked a lot with him individually, but sometimes I would work with the mother as well, and sometimes I would work with them together. And I remember one time I was sitting with them, and I was helping her, at least I thought I was, helping her to understand that, in my opinion, part of the reason that this little boy was acting the way he was acting is because he had witnessed his father physically abuse and beat his mother on a regular basis. The father was no longer in the picture, by the way. But, so there wasn't necessarily a big safety issue there for her other than what the son was doing. And we were providing intervention there. But I remember trying to convey the idea to her that the little boy was acting like that because he had witnessed Dad do it. Of course, what do we know about that? Well, we know that kids tend to do what they see their parents do more than what they hear them parents say that they should do. It's called modeling behavior. And kids tend to use modeling behavior. So anyways, I was trying to get this parent to understand that. And I was sitting there feeling pretty much like Sigmund Freud. I thought, this is good. And she seemed to be kind of getting what I was saying. So I was feeling pretty good about my therapeutic self. I thought, I'm a pretty good therapist. Out of the blue, she looked up at me and she said, Mike. At the time, I wasn't Dr. Mike, I was Mr. Mike. So she called me Mr. Mike. That was the culture of the population I was working with. So she says, Mr. Mike, the thing that would help me more than anything else is if I could just get transportation. And that hit me like a ton of bricks. Of course, she's right. Here I am trying to be all therapeutic and talk about modeling and those kind of things, which was fine, that was appropriate. But what I had neglected was to take into account that this is a person who, as a product of her environment, living in her environment, doesn't have basic resources that will allow her to regain custody of her child. Her child was in state custody. And so, yes, she wanted to address, and later on we did, his aggressive behavior. But one of her main concerns was, how am I going to get him back and forth to school or back and forth to the doctor? How am I going to get resources to take care of him and meet his needs? And that's a very valid concern that she had. So we have the ecosystems approach and the social work model. We also, of course, take the strength perspective. We don't always focus on pathology. Now, for instance, just the other day I had somebody in my therapy office came into the psychiatry clinic, and we were back in one of the offices, and this person was telling me the bad things that had happened, and that she didn't know that she could carry on a whole lot longer, and that she felt weak, and that she felt like a victim. And in one perspective, sure enough, she's right. But there's a different perspective. And so I asked her, I said, so how is it that you've managed to hang on for so long through all of this trial and tribulation that you've got, all of this trouble that you've got? How have you managed to make it from when all this started until now? And then I brought it to her attention that indeed she's a survivor. Indeed, she's tough as nails. She's been through hell, and yet she's still here. She's still putting one foot in front of the other. And that is something that requires a tremendous amount of strength, oftentimes, if you've been through very, very difficult times. And so I reminded her that she is an incredibly strong person. And then we went about the business of identifying some of the ways that she's been able to cope and that she's been able to continue putting one foot in front of the other. And we capitalized on that. We used that strength perspective. So in the social work model, diagnosis is not emphasized as much as it is in the medical model. But again, I still will make the argument that it's a useful tool, diagnosis, and I'll tell you why shortly. And now, in the social work model, the practitioner works with clients, not on them. So for instance, when somebody comes into me for psychotherapy, sometimes they will cast themselves before me and say, okay, I'll do whatever you tell me to do and fix me. And I'll say, no, that's not the way it works. You have partial responsibility here. And together, we'll work on your problems. And by the way, I don't have all the answers. Now, I may have some of the answers, and I've certainly got some clinical skills that can help us reach some answers, and that's reassuring to them that they know that. But I certainly hold them accountable to participate in their own well-being. In fact, part of that is teaching them how to be a little more self-dependent and self-reliable and all that, and to develop skills to problem solve. In fact, as you may know, there's at least one kind of therapy, cognitive behavioral therapy, which indicates that we teach the client to be their own therapist and to use those skills. But one of the things that I tell people when they come in is that it's almost like that we're in the swamp, and we're both knee-deep in water in the swamp, and there's alligators around and that kind of thing, and we're there together, and while I can't pick them up and carry them out of the swamp, what I can do is lead them out, at least most of the time, because I have a light and I know the lay of the land of the swamp. And so together, we will get out of the swamp. But I can't do it for them. They have to participate and take at least partial ownership and responsibility for that. Sometimes I liken it to driving in a car with me in the passenger seat, and I'll say, well, you may want to consider taking a turn left or right, or applying gas or applying brakes or whatever. So we work with clients and not on them. So as you can see, these models certainly present two distinctly different perspectives. And so what you'll need to ask yourself is which model appeals to you? And how could each of these be useful? Are there times when one's more useful than the other? Or do we choose one and completely throw the other out? What are the potential limitations of each approach? Is eclecticism appropriate? I want to talk for a few minutes about the Diagnostic and Statistical Manual of Mental Disorders 5, the DSM-5. The DSM-5 is used for diagnostic purposes of commonly seen mental disorders in the United States. The DSM-5 does not contain any information about treatment or intervention. It's not a treatment manual or an intervention manual. It's simply a manual used for diagnostic purposes. It does have a wealth of information in it, though, and I hope that you would spend some time looking at in depth the DSM. There are charges of validity and reliability issues, especially with the DSM-5. It's not wholeheartedly accepted. There is a bit of contention about it. In fact, the National Institute of Mental Health, which provides funding for most social service research, social science research, has, from what I understand, refused to provide funding for anything related to the DSM-5. There are charges of validity and reliability issues there. Now, I can tell you, like I said before, that when you see a person in psychotherapy, you have to provide a diagnosis and you have to use the diagnostic codes. If you don't, the insurances won't pay you for your services. And so if for no other reason, the DSM-5 is useful for getting paid, right? And we all need to make a house payment or whatever it is that we need to pay. Now, the DSM-5 provides a common language for us mental health professionals. For instance, if I'm consulting with a buddy across the hall from me, and I'll say, well, hey, what do you think about this case? And instead of going back and giving all the particulars of, for instance, major depressive disorder, I'll say simply that the person has major depressive disorder and give the rest of the details about the case. So it provides a common language. For instance, if I say somebody has schizophrenia, then the person that I'm talking with about that schizophrenia will know that it's a pretty serious, pervasive mental illness. Now, it also provides conceptual guidance. A diagnosis is useful for treatment options. For example, the treatment for schizophrenia is much different than that of conduct disorder. There's two entirely different things with two entirely different treatment approaches, okay? And so if I know a person has schizophrenia, for instance, automatically in my mind, I have an idea of what treatment can look like for that person. Same thing for conduct disorder. But it helps me to have an idea of what class of problems, class of symptoms that person likely has in order for me to know how to go forth and provide care. All right, so the DSM has 3 sections and an appendix. Section 1 is an introduction and an explanation of use of the manual. Section 2 is diagnostic criteria and codes, and it includes things like diagnostic criteria and features, associated features, prevalence of the certain disorder, the development and course of that disorder, differential diagnoses, which basically means, well, how do you know that it's this one particular disorder as opposed to something that's fairly similar? It'll give you information on that. Could also give you information about co-occurring disorders. And the third section is about emerging measures and models. And then an appendix which contains a glossary and alphabetical and numerical listings of disorders. Now, let's talk about ethics just for a second. I know that ethics is probably not your most fascinating and interesting thing to talk about, but it's actually important for a master's level clinician, especially in terms of diagnostics. Now, if you misdiagnose someone, It could be that the treatment that follows harms your client. We know that the diagnosis guides treatment, right? And so an incorrect diagnosis may lead to an incorrect and or harmful treatment. The other thing I want you to know is that diagnoses often stay with the client for years. And so over time, whatever diagnosis, or we could step out on a limb and say whatever label you put on someone can cause stigmatization and even future misdiagnosis. Now, I've seen client charts over the years, especially when I worked in an agency, that had a list of many diagnoses for a certain person. And many of them were grossly and obviously incorrect. And I could tell that they were made by several different clinicians over a period of years, a span of years. Now, sometimes diagnoses can change over time. But oftentimes, like I said, there were diagnoses that were inappropriate, that had stuck with a person for a long time. And really, if you open up a client's chart and you see a bunch of diagnoses that are different, then what that really speaks to is probably not so much that the client changes that much, which they may, but it probably speaks more to the fact that, or more to the idea that the clinicians that were doing the diagnoses weren't very good diagnosticians. Perhaps they didn't take the time to use all the information they needed to provide an accurate diagnosis. And in fact, in some cases, and in some jobs, clinicians are required very quickly to make a diagnosis, but it's a preliminary diagnosis, open for change later on, when more information comes in. So just know that, again, the things that you diagnose a person with can have some pretty significant outcomes and consequences and that kind of thing. All right, so to do a proper diagnosis, you need to do a clinical interview. It's inappropriate for you to diagnose someone that you haven't seen. Now, I remember some years ago, I was working on a very difficult case. And there was a treatment team setting, and there was a person that came in that was she wasn't involved in the case and was, I'm trying not to give out too much information here, but anyway, she was a person that was a bit of an overseer. And like me, she was a doctor and came in and gave her opinion about this particular case and what needed to be happening with the case. And her opinion differed from my opinion. And so she proceeded to try to argue with me about that case, which was inappropriate, especially in the setting that we were in. And after she got through with her ideas and her contingencies, I had one question for her. And my question, and I already knew the answer, but my question was, have you seen this client? Have you actually laid eyes on this person and spoken with this person? Her answer was no. She knew immediately when I asked the question what I was getting at. She knows that you cannot provide diagnosis unless you actually see the person. And so that one question shot down her entire argument. Now, I can also go on to say that over time, it turns out that I was right and she was wrong, and by doing what I was doing, the client got better and ended up being okay. Now, that's not to say that I know everything. I certainly don't. But I do know what I know. And I know what I know because, again, I get in the literature and I read it, think about it, apply it, that kind of thing. And I encourage you to be that way as well. If you're going to be a good clinician and be able to hold your own, and more importantly, be able to advocate for your client, then the better prepared and better educated you are, the better off you're going to be. And part of your responsibility for your education is to be a bit of a self-educator, to be able to get in the literature and read the literature. I'm going to say this again and again probably, because it's important and you need to do it. All right, so clinical interview, that's one of the practices that you need to engage in doing diagnostics. The other is to look at previous psychiatric history or psychological history for this person, to look at their records, to look at any kind of testing that's been done. You want to interview family and friends if you can, being mindful of the HIPAA laws. And you also want to look at the legal history and, is there a history of legal problems for this person and what might that suggest? Also, it's always appropriate to consult a more seasoned practitioner for guidance if needed. All right, one last thing I want to talk with you about in this unit is about coding. Now, in the DSM, you'll notice that there are, after each name of a disorder, there's a set of numbers. And that's what we call a code, a diagnostic code. All right, so it is necessary to include the diagnostic code when making a diagnosis. Without it, you may not get paid. So again, you need the diagnostic label, the name of the disorder, and then you need the code, all of which is supplied in the DSM. Now, don't be sloppy or lazy by not providing a code. I've seen other people do that, and it's just a sign that they were too sloppy or lazy to look up the code and put the code on there. You will be known in mental health circles by your work and by your professionalism, or lack thereof, okay? Now, the mental health community here in the Tri-Cities is very small. I'm from Knoxville for the last, lived there for almost 30 years. And I can tell you that even in Knoxville, the mental health community is relatively small. So the reason I'm telling you that is because you will be known in the community by what you do or don't do. And even now, in graduate school, the people that you're sitting with in class will probably be around practicing 10, 15, 20, 30 years from now, and will know who you are, and you will know who they are, and you'll know whether or not each of you is any good or not. So, anyways, don't be sloppy and lazy, use the codes. All right, so that wraps up this section. I hope that you enjoy class. I certainly hope to enjoy it as well. I'm excited for you that you get to learn about the world of psychopathology and diagnostics, and a little bit about treatment. We'll cover a little bit about that in here. And so I look forward to working with you and want you to do well in the course. If you work hard and meet the objectives, you should be fine. Okay, have a great day. Bye-bye.